A very good evening to all of you and a warm welcome to the fourth grand rounds on Uveitis, and this is being conducted by Uveitis Society of India. Today's grand rounds are going to be presented by Postgraduate Institute of Medical Education and Research, Chandigarh. But before we go ahead with the grand rounds today, let me first announce the winner of the last time's case presentation by Prabha Eye Clinic, Bangalore. A very hearty congratulations to Dr. Divya Chandran. She presented a case on a mysterious case on ocular ischemia, and she wins a free registration to the forthcoming annual conference of USI, which is going to be held on 14th and 15th of October at Hyderabad. So once again, a very hearty congratulations to you, Dr. Divya. I have the privilege and honor of introducing all our esteemed panelists for the grand rounds today. First, we have Dr. Pulido. He is the director of the Henry and Corinne Bauer Memorial Labs for Translational Medicine and Vicky and Jack Farber Research Center at Wills Eye Hospital, Philadelphia. He has keen interest in stem cell research and has more than a dozen patents to his credit. He is a world-renowned retina and ocular oncology clinician and scientist. A very warm welcome to you, sir, for today's grand round. Dr. Mark D. Smith is the CMO Precis Ophthalmic Robotic Company. He has spearheaded the development of ochraplasmin and use of intraocular methotrexate for ocular lymphomas. He also initiated the development of Precis Robo for eye surgery and is the recipient of several prestigious awards. A very warm welcome to you, sir.
Thank you.
Dr. Monsef Kerala, he works at the Department of Ophthalmology, Fatuma Barguma, University Hospital, Tunisia. He has keen interest in ocular inflammation with several publications and awards to his credit. Thank you for joining in, sir, today. Professor Amod Gupta, our very own Professor Gupta, he needs no introduction. He's a Padam Shri awardee, Professor Emeritus and Head of Ophthalmology at PGI Chandigarh, founder of Advanced Eye Center. He's well renowned for all his work on ocular tuberculosis, and he's also the founder president of Uveitis Society of India. Warm welcome to you, sir. I move on to Professor Vishali Gupta. She's head of Vitreoretina and Uveitis Services at PGI Chandigarh. She is the current president of Uveitis Society of India and secretary of International Uveitis Study Group. She is well renowned for all her work on COT study. She has more than 300 publications to her credit, and she will be speaking to us today on standardizing and simplifying the treatment for infectious uveitis. Over to you, ma'am.
Thank you very much, Manisha. And thank you, Uveitis Society of India, to give PGI MER an opportunity to present the grand rounds. The topic that I have chosen for today is treating infectious uveitis, how to standardize the treatment workflows. And I'm truly honored to be speaking on behalf of loads of my uveitis colleagues as a part of COTS, Titan, IUSG, IOIS, and FOIS. Thank you all for giving me this opportunity. So let's talk briefly about infectious uveitis. I think the biggest challenge that everybody feels is making the diagnosis, which indeed it is, but another set of challenges begin once the diagnosis is made and you have to start treatment. When to initiate specific therapy, which anti-infective, local, systemic, should you treat it with concomitant corticosteroids or immunosuppressives? If yes, what should be the timing of initiating and stopping these drugs? And finally, what is the role of the internist or ID expert vis-a-vis a uveitis expert? Now, if we look at the customary infectious uveitis management, there are lots of variations, and those variations are driven by lots of factors. The first and the foremost factor is training. There is a very brief exposure of our residents to the uveitis while they are doing their post-graduation. And generally they, just look at it and they are told that's how we do it. When you go to a practice, you generally go on with the existing process, which is a default emotion. Multidisciplinary approach is very important in uveitis, and then you have internists or ID who actually dictate the treatment of ocular disease and sometimes even refuse to initiate specific therapy, a classic example being tuberculosis. In conferences and meetings, we do have lots and lots of discussion always in uveitis meeting, where everybody is giving individual experiences with variations. So sometimes, it gets confusing for the younger generation. And when we look at the literature, we mostly have single-centered studies which are telling about the outcome in their hands. So while we have standardization of uveitis nomenclature and diagnostic criteria done by Sun 1 and now Sun 2, there is a lack of standardized treatment criteria for infectious uveitis. So over the next few minutes, I'm just going to speak about our humble attempt to create an expert consensus on treating infectious uveitis. Initially for tuberculosis, COTS consensus, a brief I'm going to talk about calculating how to give when to give treatment for tuberculosis, followed by the results of Titon group, which is the infectious uveitis treatment algorithm network, where we have submitted 2 reports on viral anterior uveitis, that is herpes and CMV, and toxo and viral posterior is on the way. So the whole story of this standardizing the treatment protocols and developing STWs began when we started collecting the real world data to see as to how we were treating ocular tuberculosis in the real world scenario all over the world. And what we found was there was a huge global variation and challenges with TB uveitis, and different people were managing it differently. So how do we reach a consensus? So we designed the questions which were based on permutations and combinations, starting with what was the phenotype, where was the patient from, was it endemic or non-endemic? What was the type of the episode? Was it the first episode or was it recurrent inflammation? Was the disease active or inactive? What were the different tests positive? And finally, we came up with a questionnaire which had quite a few questions and would take 45 minutes to complete. It was Delphi-based, Delphi 1 and 2, and both the reports of this were published in ophthalmology. The first report was with choroidal TB, and the second was with all other variables other than choroidal TB. So what was the consensus all about? The experts felt that serpiginous-like choroiditis, a picture like this is the phenotype which is very highly suggestive and compatible with tuberculosis. So they will give TB treatment wherever the patient is from, endemic or non-endemic region, if both immunological test, which is PPD and IGRA, and the chest radiology, and by positive chest radiology, we just mean not active tuberculosis, but just the evidence of some past exposure to TB. They would also treat if only the 2 immunological tests were positive, or if 1 immunology and 1 radiologic test was positive. Some of the consensus which could be achieved in Delphi 2 was because the phenotype is so strong that experts had a moderate consensus to treat even if only PPD is positive with this picture in an endemic setting and IGRA positive in a non-endemic setting. Well, we do understand we have to treat it with anti-TB drugs once we see a picture like that. And okay, so this is what you should do, start anti-infective therapy. But in reality, when you start anti-TB therapy without the good cover of corticosteroids, nearly 40% of the patients are going to have paradoxical worsening, which could either be the enlargement of existing lesion, as is shown by the black arrows, or the development of blue lesions as by the arrowheads. This paradoxical worsening typically comes in 2 to 3 weeks' time when you start anti-TB drugs, and this is what requires high dose of corticosteroids. So the experts didn't have a consensus about the concomitant use of corticosteroids, and they all agreed that to prevent paradoxical worsening, corticosteroids systemically may be initiated. And in patients where you are unable to wean them off corticosteroid, or where the disease progresses despite initiation of anti-TB drugs, you can add immunosuppressive medications. Consensus could not be reached on the intravitreal injections for paradoxical worsening. However, experts felt they definitely had a role, and it was left to treating physicians' discretion as to which one and when to use it. Coming to anterior uveitis, the consensus was not really that strong for the first episode if all the 3 tests were not positive. However, if the patient had recurrent episodes, then there was absolute consensus to treat if the tests were positive. Again, coming to intermediate uveitis, because of the real-world data available from Dr. Basu's study and from CORD's data, the intermediate uveitis patients did not really respond very well to ATT. So based on the literature and the experience, there was a moderate consensus to treat. However, for panuveitis, there was a strong consensus to treat only if all the 3 tests were positive. Coming to vasculitis, the active vasculitis, if you have and if your patient is from endemic region, you treat when both the immunologic and one radiology or one immunologic and one radiologic test is positive. However, many times this question is asked that we have done vitrectomy for vitreous hemorrhage and you did see some healed vasculitis. Should the TB treatment be given? The answer was no consensus to treat inactive disease. So this sounds good, but sitting in a busy clinical practice, it's not easy to remember or to recall these criteria. So we have devised a calculator, which is COTS calculator. And I'm very happy to share with you that this has been adopted by ICMR to be circulated to the primary care physicians all over because of its ease of use. Now, before I go on to this calculator, I would just like to say that once we are talking about TB, there are 2 things. One, you have ruled out other possible infections and you are very confident that it is TB and you want to treat the TB, ocular TB. So this is a very simple calculator. You just enter patient's name, ID, age, gender. You just enter the country. When you enter the country, it automatically takes up whether the patient is from endemic region or non-endemic. Clinical phenotype you enter, and then we have included only 3 tests, which are very basic, simple tests. And we have taken into consideration all our colleagues who are in Africa or other countries where CT scans, PCRs, PET scans, and all those fancy things are not available. So it's just simple PPD skin test, IGRA, and chest imaging. preferably CT, but if you have X-ray, or even if you don't have, you just enter whatever you have. And here you get the result within, I think it's 18 seconds or 15 seconds. It gives you the result that, well, your patient, there is a very high probability amongst experts, more than 90% would consider treating this patient on anti-TB drugs. And the results are based on publications in ophthalmology, nothing beyond that. So now from TB, let's move on to Titan, and I will briefly talk about what we have achieved so far in Titan. Titan was about treating viral anterior uveitis, which we all understand is becoming very common. It was already common in Asia Pacific region, but other countries like India, we are seeing a rising number of patients now, especially after vaccination. Herpes is kind of anterior uveitis is becoming much more common than what it was. So the report first, which has been submitted for publication, is to formulate consensus for management of HSV and VZV anterior uveitis by uveitis expert worldwide. And again, it was a two-step Delphi. Consensus was defined with more than 75% of the agreement and interquartile range of less than 1. And the consensus statements were reached. We did not encroach upon the diagnostic part because we wanted it to be a complement to SUN2 and not come up with a different diagnostic criteria. So this is in a nutshell the flow chart, which is the moral of the story, to be very honest, of a very complex data analysis that I won't be presenting. So you have a first episode of clinically suspected HSV or VZV anterior uveitis, and the signs that experts thought were important were unilaterality, increased intraocular pressure, decreased corneal sensation with diffuse or sectoral iris atrophy. So you first examine whether the patient has any clinical lesions present, which could be a blister in the eyelid, dermatomal distribution. If you do have those lesions, well, the initial systemic antiviral drugs, topical steroids, topical antiviral were plus minus, we'll come to that later. And the endpoint of the treatment was resolution of inflammation as well as normalization of intraocular pressure. The second scenario is that you do have signs in the eye, but there are no skin lesions present. So what should you do? Consider doing an aqueous tap for multiplex quantitative PCR, but do not wait for the results of PCR to start antiviral therapy. So you have done PCR, you have started therapy, IOP increased. Well, you add beta blockers, that was the drug of choice for anti-glaucoma. And if there is a corneal involvement, consider adding topical antiviral. Now you have started the initial treatment and your PCR result comes with, or you feel clinically it could be HSV or VZV. In both these scenarios, the experts did consider starting treatment with oral valaciclovir or acyclovir in the doses which are fairly standard doses. The practical tips, which personally I learned from this consensus, was there was no role of PCR in monitoring disease response, so no need to keep on repeating it, though there are experts who do, but very few. If patient stops treatment for some reason, retreat only if there is a recurrence. The need and the duration of topical antivirals was unfortunately not clear. It was about 3 to 6 months. And the maintenance treatment would be given for recurrent episodes, more than 2 recurrences a year. And it was valaciclovir 500 milligram, 2 to 3 times a day for 3 to 12 months. So we are planning to do Delphi 3 to fine tune some of these edges which are still not very sure about. The last report that I'm going to talk about is Titan 2 report, which is about treating and managing CMV anterior uveitis. Both of them had 100 experts, and all the experts completed both the part of the Delphi. Unlike COTS, the Titan was e-Delphi, so we never had a physical meeting. Again, unilaterality, increased IOP, and PCR positivity was very important for CMV to experts, unlike herpes. The moral of the consensus, just the gist of the consensus was that first-line topical ganciclovir gel here, which is 0.15%, 70% of the experts would start. The first-line systemic was oral valganciclovir, which 78% would start. Initiation with only topical or combination with systemic treatment. This was very variable actually, so we still have to work on it in Delphi 3, which would be the next phase. Topical steroid drops, 1%, at least one drop, 4 times daily for 1 to 2 weeks under the cover of antiviral, which is ganciclovir topical. Long-term maintenance treatment if required. Most of the experts would give it if the disease was chronic or was having at least 2 episodes of CMV anterior uveitis in a year. And the long term was Valgan, which was used up to 12 months in low dose. So this was my very humble kind of a presentation, just a very small attempt to standardize treatment protocols for uveitis, which over a period of time, I believe would help the comprehensive ophthalmologist, as well as our young colleagues trying to get into the uvea practice, which will help them to better manage these complex patients. Because we are all here to put a dent, whatever little that dent might be. And I'm truly, truly honored to be presenting this in front of Professor Amod Gupta, who has been my teacher, my thesis guide. I mean, from day one, he is the one who's trained me all through, and a wonderful, wonderful team, and many of those whom I could not even put the pictures here. But truly honored to have Mark. He has been with us at every step in COTS, Titan, Monsef for Titan. He's really always available. And of course, Jose. Jose has not been a part of this project, but Jose is a big part of my life and my career. Thank you guys for being there. And of course, my team, Rima, Anirudh was with us, Basav, Mohit, you will see soon, and all the youngsters, Atul and all, who honestly make life worth living. Thank you very much on behalf of the Advanced Eye Center at PGI Chennai.
Thank you, Dr. Vishali. I think that was an excellent talk, and there could not have been a better way of simplifying complicated topics such as infectious uveitis than what you presented. And especially the algorithms that you have presented, I think it's literally like a calculator, as you mentioned, for COTS and for ocular tuberculosis. I would take a quick comment from all the panelists before we move on to the case presentations, and starting with Professor Gupta.
Well, I would like to congratulate Vishali and her team of international collaborators for simplifying life for whatever worth it is. And I think it's a very, very heroic, the COTS study, which I've gone through all the papers that they wrote, and trying to simplify a hugely complex problem, in specifically recognizing the different phenotypes like tuberculosis, just like syphilis, which can have varied manifestation. So is also true for tuberculosis. I think there's not so much phenotypic variations in viral infections. The major challenge, still I feel for comprehensive ophthalmologists is an attempt should be made to improve the quality of their training and increase the period of training in the uveitis services. Because I guess there is no formal time that they spend in these areas which are becoming a challenge, world over, compared to the extraordinarily long time they spend in retina service, where I don't think there is much of a challenge. Once you know how to fix a retina, you know how to fix a retina, or how to do a laser photocoagulation, or how to give anti-VEGF injections. I think I was never very much challenged by any of the retinal disorders till we came to some of those inherited retinal disorders and a variety of genetic defects. But uveitis, and specifically the infectious uveitis, a different ball game. Trying to fix whether it's infectious or non-infectious in your own mind, I think it takes a heavy toll on you. How do we treat? And so long I was seeing patient practice, I would see day in, day out patients of infectious uveitis being treated with, corticosteroids any which way. If it doesn't work the oral way, you give it to the eye. If it didn't work, you give, deposteroids, and you give implants and whatnot, not trying to even bother to see whether these treatments are working or not. So that extent, I think Vishali and her group are doing a remarkable job in making it known not only to the specialists and comprehensive ophthalmologists, but to the general physicians. I think their efforts have led at least the Indian Council of Medical Research to recognize ocular tuberculosis as a part of the extrapulmonary tuberculosis. Till now, it was not even recognized, and physicians were very, very hesitant to start anti-TB drugs. So these are the challenges which I think they are trying to meet, and maybe take a couple of more lifetimes of young people to resolve these issues. I think great work, and kudos to her and her team.
Thank you, Professor Gupta. Moving on to Dr. Mark, any comment from your side, sir?
Well, I think I have to support what Dr. Gupta said in a certain sense. Uveitis is complex. Retina in some ways may seem to be less, but that's maybe one of the reasons there are fewer people who want to challenge into uveitis and its understanding. I think, COTS was a wonderful idea. It's not so much the idea of simplifying things. I think we all develop an approach as we go along, but to standardize it, and certainly to make the other experts in medicine realize that, there is a problem. And if anything, I've faced many times the challenge of trying to convince infectious disease specialists and internists to do a treatment that I felt was necessary. And because of their lack of knowledge, and in med school, you only get now maybe 1 or 2 weeks in ophthalmology, they really have no idea of what we do. So, I think the next step in part is, having done what we've done now, is to continue to follow and further validate what we've obtained, so that we can convince more easily all these internists to listen to us and to treat. And now we have a basis on which to check whether, the consensus obtained with specialists makes sense, because after all, a consensus is one thing. Real data is, of course, always better, but we have a start point, which we didn't have before. We all did different things. And so the challenge for the next generation in the next lifetime, I hope it's only one, that we can find really the optimal treatment for TB and the other diseases as we've mentioned. And Vishali, you did a wonderful job getting this started and doing all the work you've done so far, and getting all these people around the world to sort of collaborate and think along one line, which, coming from this, both North America and Europe, I've found a very difficult thing to do. Congratulations.
Thank you, Dr. Mark. We have a comment by Dr. Yusuf Ansari, who totally agrees with Professor Gupta that, you need a better training in uveitis during post-graduation. But he suggests that it is a good idea to have training in internal medicine, especially while you are treating uveitis patients. So I think that's an important thing, what he has suggested. I would request Dr. Monsef to have a quick comment.
I mean, just a brief comment. I'm very happy to be part of this groups. focusing on infectious uveitis, on the management of difficult infectious uveitis entities. And I would like to thank and to congratulate Vishali and the other colleagues and members of these groups. And I think a huge work has been done, and we made a lot of progress in to better manage tubercular uveitis and other infectious uveitis, but further investigations and further studies are needed to better delineate therapeutic issues, and the treatment in infectious uveitis is sometimes related to diagnosis. So there is some challenges in treatment that are related to diagnosis. So it is important to try to think about management in relation to diagnosis. And we have a lot of new other infectious entities to be covered by our work and our efforts. Thank you very much.
I'll take the last comment from Dr. Pulido.
Oh, thank you very much. I always learn from Vishali, and this was a great learning experience. And I think putting order to chaos is extremely important. And this is a step forward in putting some order into the chaos. So thank you.
So thank you, everyone. I think we've had a very interesting session on infectious uveitis. And now I would invite Dr. Mohit Dogra and Dr. Atul Arora to take over as moderators for the interesting case presentations which are lined up for the evening today. Over to you, Mohit.
Thank you, ma'am. Thank you for the opportunity. I think without wasting too much time, we'll get straight into it. We have 4 cases lined up today, and I'll be moderating 2 of them. And to kick us off today, we have Dr. Ashish Markan, and he's going to be talking to us and discussing a patient whose skin looks pretty, but the eye does not. So Dr. Ashish, please take it away.
Thank you, sir. So a very good evening to all. So the title of my presentation is that my skin looks pretty, but my eye does not. So I'll be presenting a case of a 29-year-old male who came to us with blurring of vision in both the eyes from last 3 months. He was an Indian by origin, but he was living in Canada from last 5 years. He was diagnosed as anterior uveitis in both the eyes, and patient came to us for a second opinion. So coming on to the history of present illness, patient had a similar episode in October 2020. When he had blurring of vision in the left eye, which was associated with pain and redness. At that time, he was given some topical medications and he had improvement in the left eye. Following this, he had a similar episode in the right eye also. And the patient told us that whenever the topical medications were tapered, the symptoms used to recur. Now, this was the second attack when he came to us. Patient had no history of joint pains, no history of oral or genital ulcers, and had no history of skin rashes. Patient had history of receiving a COVID vaccine 2 months before the onset of second attack. On ocular examination, the best corrected visual acuity in both the eyes was 6/6. The intraocular pressures were normal, and the pupils were normal in size and normally reacting. The anterior segment evaluation showed that there was presence of AC cells, there were fine capes, and there were no posterior synechiae. The media grade was 1+, and posterior segment evaluation of both the eyes showed that there was a disc hyperemia with blurring of disc margins, suggestive of disc edema. So OCT of the right eye was unremarkable. And similarly, in the left eye also, the foveal contour was normal, though there was presence of few cystic spaces in the outer nuclear as well as the inner nuclear layer, just in the peripapillary region. So ultra-widefield angiography was done. And ultra-widefield angiography in the right eye in the early phase was unremarkable, whereas in the late phase, it showed presence of a disc leakage, a hot disc, and presence of a 360-degree perivascular leakage. Similar findings were seen in the left eye. Though in the early phase, we could also appreciate that there was presence of these collateral vessels and there was some early disc leakage, which could be seen in the early phase also. The patient already had a few blood investigations as well as the radiological investigations when he came to us. and all of them were unremarkable. The MON2 was negative, the CCT chest was normal, MRI sacroiliac joint also patient had gotten done and was normal, VDRL TPHA was negative, even quantiferon gold was negative. And on general physical examination, we found that patient had this large tattoo on the back of his neck. And when asked about this tattoo, he told that he used to develop these bumps. And he developed these bumps in the tattoo just before the development of a second attack of uveitis. These were the bumps which were present in his tattoo. Also, he told that he reported the formation of rashes around the tattoo during the first uveitis attack also. So we just suspected that either it could be a tattoo-associated uveitis or it was a sarcoidosis which had created these bumps or granulomas in the tattoo. Though CCT chest was normal, even the serum ACE levels were normal. So a dermatology opinion was sorted. They did a patch test and the results are equivocal, and we planned for a skin biopsy. So skin biopsy actually showed presence of these epithelioid cell granulomas and foreign body type of multinucleate giant cells. Also, there was presence of green-black pigment deposition in the histiocytes and a dense collection of inflammatory infiltrates. All of these were in the favor of tattoo-associated inflammation. So this is how a magnified view of our patient looked like, which was quite different from a sarcoid granuloma. So sarcoid granulomas are actually naked granulomas. They have a paucity of inflammatory cells, and also they will not have these pigment deposition in the deep dermis, which are present in our case. So histologically, this was actually a tattoo-associated inflammation in the skin. So the tattoo can induce uveitis in 3 different forms. So either it could cause a tattoo-associated sarcoidosis, or a tattoo-induced systemic sarcoidosis, or it could be a case of a tattoo granulomas with uveitis, which is known as TAGU, without sarcoidosis. And thirdly, it could be a non-granulomatous disease where features like retinal vasculitis and cystoid macular edema can present in the eye immediately after a formation of tattoos, and it is usually a non-delayed hypersensitivity reaction. So a diagnosis of a tattoo granuloma with uveitis was made, and patient was started on oral steroids. Patient was planned to repeat a fluorescein angiography at 8 weeks, and also to start immunosuppression if there was no improvement. At this time, patient went back to Canada in November, and he was on a tapering dose of oral steroids and had a recurrence of uveitis after stopping steroids in February. At that point of time, they did an angiography there, and they found that there was still some perivascular leakage, and they started him on methotrexate along with oral steroids. So I could contact the patient telephonically, and this is the image after 2 months of post-methotrexate therapy. So the patient eye was quiet and there was resolution of tattoo bumps. So some of my questions to the panels are, is it actually a tattoo-associated uveitis, or is there an underlying inflammation which is manifesting in both the eye as well as the tattoo? And should the patient be advised a tattoo removal? And can uveitis worsen with ink dispersion while removing the tattoo? So at last, I'd like to thank Dr. Vishali, all my uvea faculty at Eye Center, as well as the Uvea Society of India, for giving me a chance to present here. Thank you.
Thank you, Ashish. Great case. Well, all I can say is I don't agree with your title. I don't think at the end his skin looked pretty either with those bumps, but great case. I'm going to pose the first question to Dr. Pulido. What is your experience, sir, on patients with tattoos and ocular inflammation, and what is your take on sarcoidosis and tattoo-induced inflammation? So can tattooing actually induce sarcoidosis, or would those patients already have a latent kind of a sarcoid thing which is tipped over the edge by sarcoids, by the tattoo, sir?
Yeah, I think it's a great question. It's fantastic presentation. And I agree with you, does not look pretty, either with or without the inflammatory reaction. But anyway, we know that there's other diseases that can induce a sarcoid-like reaction. And Saranya Balasubramaniam and I published on paraneoplastic sarcoid-like reactions in patients that have cancers. And it's known in the pathology literature that cancers can cause a paraneoplastic sarcoid-like reaction. And we published on cases of cancers elsewhere that cause a sarcoid-like reaction in the eye. And so I think that there are triggers. We're not accustomed to that. We don't read about that in the literature. but it exists, especially in the pathology literature. And I think that there are triggers that can then push a patient to develop a sarcoid-like reaction. It's basically similar to, this is a T cell response versus a B cell response for some problem elsewhere in the body.
Thank you, sir. I'm going to pose the next question to Professor Amod Gupta, sir. So again, sir, given that this patient had a triggering event in the form of a tattoo which led to the inflammation, how long would you continue immunosuppression in this patient, sir? And would you advise tattoo removal? I know it's a tough question, sir, but that's why I'm posing it to you. You're muted, sir. Sorry.
Yeah. Mohit, it's $1 million question whether he would like to have the tattoo removed. It's a pretty big tattoo there. But if I were in his place, I would get it replaced. I would get it removed and maybe have some kind of skin grafting there. Or I don't know how they actually remove it. Because so long this tattoo remains, this is the inciting event. There's no doubt about it. And there are several reports going back, almost 50 years and more, where removal of the tattoos has led to questions of the eye. There was never a recurrence of uveitis. And this is going to persist. I'll just like to cite, a case that we published almost 20 years ago of a corneal tattoo. And this was a guy, and this used to be in fashion those days. People with peripheral corneal opacities, to prevent scattering, would get a black colored tattoo. So this guy got a tattoo done for the corneal scar in the periphery of the cornea. And within 3 weeks, he had inflammation of this cornea. And, it was debrided. We looked for any infective organism, including a fungus. Nothing worked. And he was treated on steroids, antifungal agents, and ultimately the lesion resolved. But a year and a half later, we did a corneal grafting on the patient. And this corneal graft was, the removed cornea was submitted to the Armed Forces Institute of Pathology. Dr. Hidayat there, the pathologist, looked at the pathology, and it was still there. The granulomatous keratitis and keratouveitis this patient had, although clinically the removed corneal button was all right, but it showed again multinucleated foreign body giant cells, the epithelioid cells and inflammatory cells. And I am sure that this was inflammation which was lurking on. So I don't know how do you convince. Number 2 point which I would like to make here is looking for this tattoo. Some of the populations in the Western world, I think, have a large number of population, almost like quarter of population would have, tattoos at any different places, visible or invisible. And the size may be, the entire arms or forearms may be tattooed. And I don't know whether it's related to the size of the tattoo. It's obviously not a very frequent occurrence. Not more than 50, 60 cases are known in the literature, but they're well known for the last 70, 80 years. This problem is there, and it could present many a times like sarcoid-like uveitis. And we know that sarcoid, physicians look for any scars in the body, any keloids or any scars in the body to be able to do a histopathology, to diagnose ultimately the sarcoidosis in patients. So from that example, doing a biopsy in this patient did help in establishing a diagnosis of a sarcoid-like or a granulomatous inflammation, whether most likely related to the pigment which they use. We don't know how these pigments work. And or is it some kind of the normal commensals in the skin that gain entry, and it's the microbiome of the skin playing a role there more than just the pigment or the whatever. We don't know. These are unanswered questions. But certainly the flu vaccine, I think in a way, did precipitate the COVID vaccine, did precipitate his second event. Thank you.
Thank you, sir. That was going to be my next question, sir, about the COVID vaccine. I'm going to pose the next question to Dr. Mark T. Smith. So would you think that a skin biopsy is required for diagnosis, sir? And the second part to that is, if a skin biopsy is done, as was done in our case, and it did show some evidence of, as we would expect, some granulomatous inflammation with some of those pigment-laden macrophages and posterior segment ocular involvement in both the eyes, would you initially just want to treat with steroids and not with steroid sparing agents, or would you want to add them straight away if the patient is reluctant for tattoo removal, sir?
Well, first of all, with tattoos, the persistence of the tattoo has to do with the fact that the pigment sits in macrophages. That's why it doesn't disappear. And if the macrophage dies locally, essentially it's taken up by other macrophages and it diffuses over time as the tattoos usually spread. The second thing is your pigment changes over time. And unfortunately, there's not good regulation in the world for blue pigment. There was a time where they were using, in fact, mercury. So it gives you an idea of how far people could go. That's been outlawed now, but how far people may go. So maybe this is an illegal pigment that was used, even though it was done supposedly in Canada, where you'd expect people to try and be quite careful with what they do. I think the biopsy is essential here to know exactly what's going on. So it does show you that the inflammation is causing you a granulomatous-like response, whatever you want to call it. It's sarcoid-like, and so, it can diffuse elsewhere. Why is it occurring in this man? Maybe it has also to do with the fact that he has a very pigmented skin and it's now affecting the optic nerve. Had it gone on, would we have seen a VKH-like response? I don't know. But I think the first step is to try and control the inflammation, make it disappear locally, because that also has an effect on the eye. And probably, if you look at what dermatologists recommend, is essentially a control with immunosuppressive drugs to try and prevent the recurrence. Whether we should remove it or not, I think, is something that should be decided in collaboration with dermatologists. I don't know how deep. This looks like a very thick tattoo. Could it be removed with laser ablation? I'm not so sure, but that would be probably the preferred technique rather than a surgical one. And maybe reducing the dose, the amount of pigment that is present in the skin might help matters in this individual. But as was mentioned by Dr. Gupta, there are only so many cases reported, and I think it's underreported because it's not something that we're requiring authorities to report. And you're right, given the number of tattoos around the world, I'm sure that people like this wouldn't even show up unless they had an effect somewhere elsewhere than just in their skin. And I'd like to thank the person from presenting this, because I have a 23-year-old daughter who's been telling us for about a year now that she'd love a tattoo. And the first thing I did when you had this case is I showed it to her and I said, look, you're not going to get a tattoo because otherwise you might get into trouble. So thank you very much.
So Ashish gets extra points, not just for presenting the case, but helping Dr. Mark Smith out as a dad. So
exactly.
Good on you, Ashish. I'm going to post the last question of this case to Dr. Monsef. And this is a little bit offbeat. So we just heard Dr. Vishali talk about infectious uveitis. Given, and someone had posted a similar kind of query in the chat box. Which infectious agents would you consider, sir, given that sometimes there is cross contamination with needles when these tattoos are given, might not be the most clean environment where some of these areas where people tend to get tattoos, maybe not with the clinical picture that this patient had, but with, let's say, a unilateral severe panuveitis kind of picture. Any infectious agents you would like to rule out in that scenario, sir?
Thank you for the question, and I agree with all previous comments. And it's important, I think, that to think about this cause of uveitis, and I agree that the rate of tattoo uveitis is probably underestimated in our clinical practice. And however, there are more and more new cases published due to the increasing number of tattooing in some countries. In the present, so we have to ask all our patients with uveitis if they have a tattoo. This is very important, and the pattern of uveitis in this patient is compatible with the diagnosis of tattoo-associated uveitis. However, as mentioned before, we have to look for sarcoidosis due to the connection between this pattern of the pattern of this entity and sarcoidosis. And the other important issue is to exclude the infections. However, in such cases, my workup is a workup for classic infectious uveitis, so tuberculosis, syphilis in particular, and we don't look for other specific infectious causes. This is very, very typical for tattoo-associated uveitis, but I agree that an infectious etiology should be excluded before this diagnosis is made.
Thank you, sir. Thank you. Thank you. And I thank all the panelists, and thank you, Ashish, once again for that very, very interesting case. And with that, I hand over the podium to my colleague.
Please, if you do not mind, regarding laser tattoo removal, I think that this option, I would not recommend laser tattoo removal because I think that this could expose additional pigment to the immune system and promote further inflammation. So, as Ahmad mentioned, this is a very large tattoo, so surgical removal cannot be considered, and laser is not a good option to be for this case.
I would, I'd like you guys to consider sending, if you still have some sample for heavy metal analysis, because we know that beryllium can cause a sarcoid-like reaction. And there is, I was just looking at it right now, there is beryllium in tattoo pigments. So that would be very interesting to do that.
We'll figure that out. Thank you.
Thank you, sir. And Dr. Monser's last query also, I think, answered one of the last questions in the Q&A box. So thank you, sir, for that. And with that, I'm going to hand over the the podium now to Atul, my colleague, and he's going to moderate the second case by Dr. Sabia. Dr. Atul, it's all yours.
Thank you, Dr. Mohit. The next case shall be presented by Dr. Sabia Handa. He is currently a fellow with us, Vitreoretina and Uveitis Services in PGI. She shall be discussing an unusual case of intermediate uveitis. Over to you, Dr. Sabia, for the presentation.
Good evening, everyone. I would like to thank Uveitis Society of India for giving me this opportunity. So my case is an unusual case of intermediate uveitis. Does this patient need biologics? So my patient is a 47 years male. He presented to us in January in 2020 with complaint of diminution of vision in left eye for 1 year, which was gradual in onset, painless and progressive, and was associated with previous episodes of foreign body sensation and redness. The patient had previously taken consultation at another center in Delhi, where he was treated with oral and topical steroids and with a poor response. And he was being sent to us for upgradation in his treatment, and he was being considered for biologics. So at presentation, the visual acuity in right eye was 6.6. However, in left eye was 660, which was not improving with pinhole. IOP was within normal limits. Pupils were normal in size and normally reacting. Anterior segment examination of the right eye was within normal limits. However, in the left eye, there was presence of 1+ cells, 1+ flare, no posterior synechiae with a posterior subcapsular cataract. This was the right eye posterior segment examination, which was within normal limits. And this was the left eye posterior segment examination. The visual acuity was 660 in this eye. There was presence of 3+ vitreous cells and 2+ vitreous haze. However, the disc and the vessels were within normal limits. So provisional diagnosis in this patient was left eye intermediate uveitis, and the differentials that were considered were sarcoidosis, tubercular intermediate uveitis, primary vitreoretinal lymphoma, and pars planitis. So the plan was to go ahead with the ancillary investigations and the laboratory investigations. This was the fluorescein angiography. The right eye fluorescein was within normal limits. And this was the fluorescein of the left eye. We can see that there was diffuse vascular leak in the left eye along with leakage from the disc as well as cystoid macular edema. This was the OCT of the right eye, which was within normal limits, and the OCT of the left eye revealed cystoid macular edema. There was presence of intraretinal fluid as well as subretinal fluid on OCT. So the laboratory investigations revealed a negative MON2. Tests for syphilis were negative. CT chest was negative. ACE levels were within normal limits, and HIV was non-reactive. So at this point, we took a detailed retrospective history, and patient told us that he has trauma to the left eye with caterpillar hair while riding motorcycle 4 years back. He had a caterpillar hair falling on his cornea and as well as conjunctiva, which was removed under the microscope, and following which he continued to have foreign body sensation. And also there was history of left eye sectoral episcleritis. So after receiving this retrospective history, we again examined the patient in detail, and we saw that there were 3 hair-like extensions in the nasal aspect of his left eye, as outlined by these circles, which were suggestive of caterpillar hair. So after taking the retrospective history and examining the patient in detail, our final diagnosis was left eye caterpillar hair-induced intermediate uveitis. And as we know that these caterpillar hair are known to reside in the pars plana, we went ahead and did a UBM, and there was no hair found in the ciliary body region. So we took the patient up for left eye phacoemulsification with IOL implantation, a pars plana vitrectomy with a caterpillar hair removal under local anesthesia under perioperative steroid cover. The vitreous samples were sent for cytology and flow, and postoperatively he was given intravenous dexamethasone. So this is the short video clip showing the various surgical steps. After draping the patient, a left eye phacoemulsification and IOL implantation is done. And here we can see a core vitrectomy is done. So after completing the core vitrectomy, a vitreous base dissection is done. And while doing the vitreous base dissection, we can see that the caterpillar hair is now seen here, which is removed using the cutter. So another caterpillar hair is again seen here using the scleral depression, and the capsule around it is removed using the cutter. And again, the hair is removed using the forceps. So following removal of these, a complete 360-degree assisted scleral depression vitreous base dissection is done to rule out presence of any other hairs that might have been missed on clinical examination. And fluid air exchange is done, and the surgery was completed. So fluid air exchange is done, and the sclerotomies are sutured. The vitreous sample which was sent for cytology revealed few mature lymphocytes without any blasts. And follow-up examination at 6 months revealed resolution of inflammation. The visual acuity of the patient improved to 6/12. Also, there was resolution of the cystoid macular edema. So the take-home points from this presentation were that every uveitis patients, especially the ones which are not responding to steroids, warrant a detailed clinical examination and detailed history. And early diagnosis and timely removal of caterpillar hair plays a vital role in preventing the loss of eye due to extensive recurrent inflammation. I would like to thank and acknowledge my faculty and my colleagues at Advanced Eye Center. Thank you, sir.
Nice presentation, Dr. Sabya. Really an interesting case of patient non-responding to treatment, and it's important to clinically evaluate the eye and ask relevant history. I would first like to go to Dr. Monsef for some quick comments on the case, sir.
Thank you very much. I thank you for this very nice case, and I think that this case highlights the role of history taking, a careful history taking in any patient with uveitis to exclude a history of trauma, and we have to search very carefully for foreign bodies, and particularly in eyes in patients with uveitis not responding very well to steroids. So we have to, and I think that a missed intraocular foreign body is an important cause of masquerade syndrome, and we have to keep that in our mind because the intravitreal foreign body should be removed, and this is the treatment option to have a good outcome, and any delay in this surgical removal can induce severe consequences due to chronic inflammation.
Thank you, sir. As most of the time these cilia or the hair are impacted in pars plana also, so in such cases the investigations like UBM may have a role. I would like Professor Amod sir to comment on this. Like if a patient is non-responding to treatment, the stepwise approach is you go for the diagnostic therapy, diagnostic vitrectomy also. But before that, it becomes important to do IO or do UBM. So, any your comments on this?
Atul, I have a couple of comments. One is I must congratulate Sabya for presenting this case to the world community because it's an extremely unusual case of intermediate uveitis. And I doubt if anybody would specifically ask the history of, a foreign body in the eye or a caterpillar in the eye. I mean, nobody would ever think of asking that kind of a question. And I'm not sure how this history got elicited. It's a very interesting aspect of this case as well. As far as the UBM is concerned, personally, I have removed in one odd case, these caterpillar hair from the ciliary region or the periphery of the retina. And most often, they would be oriented vertically. And you can pick them up, the granulomatous inflammation on UBM, certainly that's one indicated. But these are the kind of cases you already know because the patient has come to you with corneal erosions, and on everting the lid, you can see those caterpillar, some of those still sticking out from the palpebral conjunctiva, as you work the lid. So you get an occasion to see and look for in the ciliary body or those which might have penetrated, because they'll keep penetrating from the skin surface and go into the eye. So I think the severity of inflammation in this patient is because they have completely penetrated the sclera, the choroid, and the retina, and lying on the surface and accumulating those exudates, which will kind of give away, clue as you did the vitreous surgery. Normally, what I would do is depress, do a scleral depression, where even if it is vertically oriented into the eye, as you depress, they would stand out, they would protrude into the vitreous cavity a little, and there you can grasp it with the hand gripping forceps and remove it. You cannot pull them out. This has to be remembered. You cannot pull them back from the route they followed, into the eye. You have to grasp the leading tip of the hair for removal. And I think once it has gone into the completely into the intraocular area, then it's of course easy. But I would have done a little more depression all around and looked for. I'm sure it was done for this patient as well. But one of the most remarkable causes of intermediate uveitis, and I think she ought to publish it sooner than later, because it will add extremely valuable differential diagnosis to intermediate uveitis. Well, thank you.
If I might add, we did not ask the history straight away. I mean, as usual, the patient came for biologics. We get all the multimodal done. We don't even pay attention. Then when doing clinical examination, there were two of them lying posteriorly. We wondered what they were. And to be very honest with you, caterpillar was not our first thing, but they did not look like anything else. Then the patient gave history that 2 years ago, or whatever it was, he was driving a motorbike and something fell, he rubbed. He went to the cornea surgeon who had removed the caterpillar hair from the cornea. And after 6 months later, he started developing these symptoms, and then immunosuppression, corticosteroids, and then biologics, and that's how he ended up. Thank you, sir.
It's a wonderful patient, it's a wonderful patient, and I think great learning from this patient. Well.
Thank you, sir. It's important to ask leading questions based on your examination, like in this case. I'll move to Dr. Jose, sir, for this. Sometimes the history may not be there, and on clinical examination, the cilia or maybe in the periphery. So the stepwise approach would be, if the patient is not responding to the treatment, you go ahead with diagnostic to get a sample and testing done. So while doing diagnostic vitrectomy, it would be important to evaluate 360 degree, and any specific tests that additionally you would like to send, like would you suspect eosinophils to be raised from vitreous sample? Dr. Jose, sir.
Yeah. Well, first of all, thank you for this case. Everything that I learn about caterpillar setae, I've learned from Vishali. So I'm definitely not an expert in caterpillar setae. But I think it is important in any case of doing a vitrectomy in eyes with inflammation to send some samples for either 16S and 18S RNA PCR, or to send it for in thioglycolate, which anything grows in thioglycolate. The other thing is that if you do remove a foreign body, it is worthwhile to dip that foreign body in thioglycolate, because what happens ultimately in lots of these cases is you're so excited about having removed it from the eye that you forget, once it's outside the eye, your obligations, and your obligations still continue. And that is to document that the size and document what it looks like outside the eye, and then to consider sending it for culture and then pathology. Thank you.
Thank you, sir. We have discussed most points. Some quick comments from Dr. Mark Desmet on this case.
Yeah, maybe a few. First of all, when I looked at the differential, we never mentioned trauma or infection, and yet you have here unilateral inflammation that is very severe. And I think that's something that should always be in the back of our mind if we're seeing that on the one side, whether it's an endogenous infection. Trauma can sometimes hide itself very, very nicely. I can remember a case a little bit like what Jose is alluding to, a very small fragment that penetrated through the cornea, through the inferior iris, lodged into the pars plana, and even with transillumination, we saw virtually nothing. And yet a good indentation with an indirect allowed us to find it. And so I don't know if with indentation, these hairs would be visible, but I think one has to think about that. The other comment I wanted to make was, so this hair penetrated through, we don't really know where it went in and how it migrated through into the vitreous. Another case I can remember many, many years ago before I started my clinical practice, there was a time where people used very small round bands to be able to indent the retina through the sclera when there was a retinal detachment. And I saw a patient that presented with a band that was subretinal. There was no evidence on the surface. It looked normal, and yet this band was present subretinally. So being able to migrate from the surface through the sclera, through the choroid into the vitreous is possible for if it goes very slowly. And the only way we could resolve the problem for this woman years ago was to essentially dissect through the sclera, make an opening, and remove the band. So, maybe we don't see it. There's no sign on the outside, and yet there's something inside the eye on just one eye. And, foreign body, trauma, infection have to be, top of our list if it's just unilateral.
Thank you, sir, for the valuable comments. Now, we shall move on next case. I'll hand over the dice to Dr. Mohit for the next case.
Thank you, Atul. And from really, challenging cases of skin tattooing and caterpillar hair in the eye, we're going to change tracks a bit. And Nikita is going to be talking to us on a case of vexing panuveitis in a monoocular patient. Nikita is one of our, brightest young MCH passouts. So all the best, Nikita. Over to you.
Good evening, everyone. So my topic is vexing panuveitis in a monocular patient. Our case was a 40-year-old Kashmiri female who presented with vision loss in her right eye since 1.5 months, which was not associated with redness or photophobia. Her left eye had undergone phthisis.
Nikita, your slides are not moving. You're not on the slideshow, please. Can you correct that?
Okay, sir.
We can still see your title, your first slide. Yes, please. Thank you.
Is it visible now, sir?
Yeah, we're on the second slide. Can you just try and move one slide forward and then come back to this, please? Yeah, I think we're good. Yeah, please start.
So my case is a 40-year-old Kashmiri female who presented with vision loss in her right eye since 1.5 months, which was not associated with redness or photophobia. Her left eye had undergone phthisis following trauma in childhood. On examination, the right eye had a visual acuity of hand movement close to face with an intraocular pressure of 12 millimeters mercury. Anterior segment examination revealed a clear cornea, no KPs, presence of AC cells 2+ and flare, and minimal posterior subcapsular cataract, with presence of vitritis 2+. Fundus examination revealed media clarity grade 2. The disc was hyperemic, with presence of yellowish subretinal elevated lesion in the peripapillary area and multiple small round yellowish discrete lesions in the nasal periphery. Most of them were along the vessels. However, some were also confluent and they were more confluent in the temporal periphery. On eliciting treatment history, the patient was on oral acyclovir since 20 days, started from outside, and had also received an injection of posterior subtenon Kenacort 10 days ago. There was no history of receiving any oral or IV steroids. Investigations carried by the patient ruled out any infectious etiology, and also a CE MRI brain was normal, along with the normal CCT chest. Fundus autofluorescence of the right eye showed a hyperautofluorescent lesion in the peripapillary area, and the chorioretinal lesions in the periphery showed a hypoautofluorescent center with a surrounding rim of hyperautofluorescence. The OCT scan through the macula showed normal inner retinal layers, a pocket of subretinal fluid at the macula, a uniformly hyperreflective subretinal material extending from the disc temporally, with disruption of the outer retinal layers, and a variable choroidal thickness. The subfoveal choroidal thickness was 330 microns, and we can see compression of the choriocapillaries layer. However, the choroid was thin in the region temporal to the macula. Fundus fluorescein angiography showed hyperfluorescence of the chorioretinal lesions in the early, mid, as well as late frames. And the peripapillary region showed staining in the late frames. Also, there was some diffuse vascular leakage in the temporal periphery. So at this point of time, the differentials we kept were multifocal choroiditis with panuveitis. Based on the history of trauma in the fellow eye, we also kept the differential of atypical sympathetic ophthalmia. The other differentials were primary or secondary vitreoretinal lymphoma and viral retinitis on antiviral treatment. So we decided to review literature, and we found that there were similar case reports of subretinal fibrosis and multifocal granulomatous chorioretinitis published by Gass and Wong et al. In different articles. And they had similar case presentations as in our cases. And the enucleation of the fellow eye in all these cases had shown features of granulomatous inflammation in the region inner to the Bruch's membrane with disruption of outer retinal layers. And Wong et al. Had also proposed it to be a variant of sympathetic ophthalmia. There's also a case report from our side of the world showing similar features of subretinal fibrosis mimicking retinal necrosis. And this case report highlights the dismal visual prognosis in these patients despite maximum immunosuppressive therapy. So we also decided to take our patient for enucleation of the fellow eye. And histopathology of the enucleated eye revealed dense lymphonuclear inflammatory infiltrate, multiple granulomas with multinucleated giant cells in the outer retina, and presence of collagen with fibroblasts in the region above the Bruch's membrane. The features were suggestive of sympathetic ophthalmia. Immunohistochemistry of the enucleated sample revealed predominance of CD20 positive B cells. We again went back to literature review and found that chorioretinal biopsy of the eye in such a similar patient has revealed, the immunopathology had revealed aggregates of CD20 positive B cells. And they've also attributed the rapid clinical course in this patient to the unique immunopathology. But however, this case was not treated with any anti-CD20 antibody. But there are case reports of diffuse subretinal fibrosis uveitis syndrome treated with rituximab, which is a monoclonal antibody against CD20 positive B cells. And both the cases in this case report showed a non-progression of subretinal fibrosis with eyes remaining white for a long time after treatment with rituximab. So we also decided to start our patient on IV methylprednisolone along with rituximab 1 gram infusion, which was given on day 0 and repeated 2 weeks later. And this is the fundus photo and the OCT after 5 doses of IV methylprednisolone, where the subretinal fluid had started showing signs of resolution. And 2 weeks later, when the patient was shifted to oral Vizolone and tablet Azuran, the subretinal fluid had completely resolved. This is the last follow-up available at 2 months, where the visual acuity had improved to 4/60. Media clarity had also improved, and the subretinal fibrosis had stabilized with clearer demarcation of its boundaries, and the OCT showed no subretinal fluid. So my questions to the panel are whether this case represents a variant of sympathetic ophthalmia, or is it a different entity of progressive subretinal fibrosis with multifocal granulomatous chorioretinitis? And how early should we go for a diagnostic chorioretinal biopsy or enucleation of the fellow eye for a histopathological diagnosis? And we have rapid progression of such eyes despite maximum immunosuppressive therapy. And is there any other treatment modality that could be suggested for these patients? At the end, I would like to thank all my seniors and fellows at Advanced Eye Center for the valuable support, and USI for giving me this opportunity. Thank you.
Thank you, Nikita, for finishing on time and, cramming a lot of information in that. So I think great presentation, lots of food for thought. I'm going to go to Dr. Monsif first this time, sir. Again, your take on this case, given that, so there are quite a few obviouses in this case. The monoocular patient, the fellow eye had panuveitis. So, I mean, a sympathetic ophthalmia would definitely come to mind, but there are also a lot of atypicalities that Nikita highlighted. So how would you have approached this case? Anything you would have done differently, sir?
Thank you very much for your introduction. And I agree that with the diagnosis proposed by Nikita and the differential diagnosis based on clinical features. However, with the presence of a history of unilateral trauma and with the multimodal imaging showing choroiditis, a diagnosis of sympathetic ophthalmia can be easily made in this patient. The presence of subretinal fibrosis is not uncommon in patients with SO, as well as in patients with VKH. However, the severity of this subretinal fibrosis is a bit unusual, is a very severe subretinal fibrosis. So in summary, I think that a diagnosis of SO is evident to me. And however, we have to exclude and to other differential diagnosis and to think about other diagnosis, but this is just a severe case of sympathetic ophthalmia seen late in the course of the disease. I think more than 6 weeks after onset of. So in terms of diagnosis, I think that the diagnosis is easy to make.
Thank you, sir. Thank you.
Thank you.
I'm going to pose the next question to Dr. Mark. So given that, the diagnosis was there and this patient was already treated with, had been to a couple of centers, was diagnosed to have, acute retinal necrosis kind of picture, started on oral valacyclovir. Center B actually thought that it was something which was immunological, and the patient had received posterior subtenon Kenacort injection about 8 to 10 days prior to presenting to us. So given that there was and so obviously when the patient came to us, there was a lot of inflammation in the eye, both in the anterior and the posterior segment. So it didn't seem to be responding to the antivirals or the local steroid injection. So given that milieu that we saw the patient in, would you like to treat this patient differently? Would you want to look for some alternative immunosuppression? Would your approach be the same? Your thoughts, sir?
Well, when you look at the picture, what spoke a little bit against, let's say, sympathetic was the thickening of the choroid was relatively low. And in a situation like that with the OCT, I would try to look at some of the lesions to see whether, you had all these yellow spots, some of which look like essentially Dale and Fuchs nodules. So in a Dale and Fuchs, you'd expect an elevation of these lesions if they're active, and the other ones that are larger were probably atrophic. So to help me go in the right direction, I would have tried to look at these lesions with OCT and try to see whether we had some elevations that could correspond to on pathology at Dale and Fuchs. The diagnosis to me, all uveitis, when they get out of control, they sort of go towards this B cell type of inflammation and subretinal fibrosis. So the picture looked like subretinal fibrosis. And so I would probably try to treat that. And I would agree with the idea of taking the eye that was blind or nearly blind and finding out on histology what we have there to rule out sympathetic. And there are some old case reports that suggest that if you take that, you remove some of the inciting events and might improve, in fact, even the diagnosis. And to come to your question, I would try to do anything I can without touching or getting a sample from the eye that is now active in the only good eye, because of this concept of maybe having sympathetic in the background, and try to rule that out before I would rule in anything else. What would I have done if you came back and you didn't show any granulomas inside the eye that was enucleated? I'd probably just try immunosuppression with rituximab, or with something that works also quite well as sirolimus in these cases, and try to see first after a number of weeks what we're able to find. If infection was a possibility, I do whatever test you can think of systemically to try and see whether there's any evidence of an active infection process, whether it's viral or others, but just using the systemic approach before even touching the eye. But I think you did the right thing. You followed the sequence of events which made a lot of sense, and you came to the right approach for this particular patient.
Thank you, Dr. Mark. I'm going to pose a tough one to Professor Gupta now. We recently had a similar patient, sir, who was again a young Kashmiri female, one-eyed. Unfortunately, we've had lots of trauma in that part of our country. And she was actually, being treated as a case of sympathetic ophthalmia by the treating ophthalmologist. And she was on 125 milligram oral azoram. And in November, and she came to us, I think, in January. in January this year, but in November, as per the notes, the referring ophthalmologist actually wrote that, she had a sudden flare-up of inflammation, had panuveitis, had KPs, and he thought that, and she also had these yellow lesions in the periphery, and he thought that this one-eyed lady now on tablet Azoran, which she was taking for the past 125 milligram for the past 6 months, had now developed a viral retinitis. So he stopped that, and he started her on oral antivirals and referred her. So just your take on that, sir, given that apart from the diagnostic challenge, there's also a therapeutic challenge in these eyes that in contrast to your garden variety, if I can use the word, sympathetic ophthalmia cases, these will not respond to a single oral steroids tapering dose over a long, slow taper with Azoran or methotrexate, and would require something a little beyond that. So like this patient and the one that I was just mentioned.
I think, the question was asked by the treating physician, even in this patient, that did she have a viral retinitis? And if you recall my comments after Dr. Vishali's presentation, that is the confusion in the mind of comprehensive ophthalmologists and many of the so-called experts. Is it infective or is it autoimmune? I mean, I don't see any reason why you would confuse a person. Once you look at the OCT in this patient, for instance, which shows a subretinal fibrosis, I cannot imagine a viral retinitis producing that kind of massive subretinal fibrosis, either clinically or on OCT. I think that's somebody's imagination working, they are thinking of viral retinitis. Whatever viral retinitis I have seen is CMV retinitis in the context of depocorticosteroids into the, say, like intravitreal triamcinolone injection leading to a localized CMV retinitis, because of the intense localized immunosuppression. But in my exhaustive experience with using azathioprine in several hundred patients, I don't think I ever saw a patient who developed a viral retinitis. Now, what happens with azathioprine and with corticosteroids when you treat your patients a long-term, these kind of therapies, they are not very easily tolerated. And the patient would perhaps miss a dose or two and not tell you. And I burnt my fingers treating a young child and kept on increasing the dose of immunosuppression and corticosteroids till, I forced him to admit that, if the mother supervised the taking of the tablet, he was doing it, but otherwise he would spit it out or he would not even take it. And, after a couple of years, this got revealed to me, and it was a revelation, true, that the compliance with the treatment is not as what we believe the patient to be telling, and they may be non-compliant. So if a person who's well controlled on a given immunosuppressive therapy suddenly flares up, it's an unusual setting, I would not really believe that to be, and not change the line of treatment, and rather insist on the compliance issues with the taking of the treatment. The second issue in this patient, I think the question of sympathetic ophthalmia versus multifocal choroiditis, progressive subretinal fibrosis, these are the two competing diagnoses in this patient, and I doubt if histopathology has been able to sort that out, and I think I agree with Mark that maybe we could have done a little more meticulous, OCT scanning of those areas where you had those small, tiny, what looked like Dellenflux nodules. Now that reminds me of a very interesting picture of autofluorescence which was shown, which shows these perivascular, tiny, discrete autofluorescent lesions, which previously I have seen in a presentation by Narsingh Rao, and when he was showing some cases of autoimmune retinitis. So there is some element of probably autoimmune retinopathy in this particular patient as well. But the good news here was that at least you could remove the dead eye or the blind eye, which not many people agree to the enucleation for cosmetic reasons, for psychological reasons, but it was a good thing that it let you. I would not do a biopsy in this patient, in the seeing eye at any cost. And I would treat it, and I think you guys manage that patient very well. And the poor visual outcome is essentially because of the extensive fibrosis this patient has. So my thought would be more in terms of sympathetic and multifocal choroiditis, panuveitis with progressive subretinal fibrosis. So these patients do require very extensive immunosuppression. And since she has responded to rituximab and the other immunosuppressive agents, I would like to continue and keep this patient under watch. Her vision is very precious, makes her ambulatory at this time, but she could lose it if we lose track of this patient. Thank you. Wonderful patient, I must say.
Thank you, sir. Thank you. Thank you for all those comments. Dr. Jose, I'm going to come to you finally, sir, with this, and going to pose going to pose a question on histopathology and so let's say in this patient we were able to get the fellow eye out, and in contrast to our regular sympathetic ophthalmia, in which we tend to get more of T cells, we got more CD20 positivity or B cells in this. And since we have rituximab, something which is available, we can give it fairly readily, and we do not have an anti-CD3 or a CD2 or an anti-T cell specific antibody per se. Had it been the other way around, had we just had, let's say, more T cells than B cells, which a lot of these sympathetic ophthalmia patients tend to get, would you still have wanted us to continue with rituximab, given that there was no evidence of as many B cells? Or do you think it's too premature for us to base our therapy based on the predominance of cells on any histopathological sample?
Yeah, so that's a great question, and I really appreciate all the comments from Dr. Gupta, because I sure learned a lot from him. We know that we look at uveitis as B cell, T cell, but it's really a spectrum, right? And yes, we put sarcoid and we put VKH in the T cell box, and we put things like autoimmune uveitis in the B cell box, autoimmune retinopathy in the B cell box. But there are cases of autoimmune retinal diseases, for instance, MAR, for instance, melanoma-associated retinopathy, that also can have multifocal choroiditis with it. And there's now a few cases, especially after the use of checkpoint inhibitors. So it's really a spectrum. And yes, I think starting first with anti-T cells, and there are antibodies, there are directed against T cells. The problem is they cause severe disease. And so they were on the market and were removed from the market. But things like azathioprine can help with the T cell component. And I think one shouldn't just go straight to rituximab in these diseases that tend to be more towards the T cell spectrum, but start like you guys did with anti-CD3 cells, and then go, if that's not sufficient, then go for the rituximab.
Thank you, sir. Thank you. Thank you. Thank you to all the panelists. Thank you, Nikita. Great case. And I'm going to hand it over to Atul for the last case. All yours, Atul.
Thank you, sir. So last case for today shall be presented by Dr. Uday. I did laser in good faith, and what happened? Dr. Uday, please.
Good evening, everyone. So is my presentation visible?
Yes, very well visible. Go ahead.
So, so my topic is I did laser in good faith, and what happened? So right at the outset, I'd like to acknowledge all my seniors and my colleagues at the Advanced Eye Center. So coming to my patient, she's a 32-year-old female who first presented to us in September last year with painless progressive diminution of vision in both the eyes, right more than left, in 6 months. She's been on and off steroids since 6 months, and she stopped 1 week prior coming to us. And whenever the steroids were tapered to below 20 milligrams, she had a worsening of her in diminution of vision. There's history of recurrent oral and genital ulcers, and she had developed a lot of joint pains and facial puffiness with the steroids. So this is the clinical picture when she came to us in September 21 with a visual acuity of counting fingers, a pressure of 16. There were keratic precipitates and 1+ cells in the anterior chamber with a 1+ vitreous haze. We could see a pale disc. The retinal vessels around the disc seemed okay, but peripherally we could see multiple areas of retinal infiltrates with some retinal hemorrhages as well. And this is the mid-phase angiogram of the right eye, which actually showed diffuse small vessel vasculitis in a fern pattern with a lot of capillary non-perfusion areas 360 degree. So the left eye, her visual acuity was 6/18 and a pressure of 14, and the anterior chamber was essentially quiet. But on evaluation of the fundus, there was these few retinal infiltrates present temporally as well as nasally. And inferior nasally, there was presence of occlusive vasculitis sort of picture with hemorrhages as well. And this is the mid-phase angiogram showing a similar picture as the right eye, along with presence of macular ischemia. So we did a detailed uveitis workup for her, including syphilis serology, HIV, everything was negative, and we came to a diagnosis of Behçet's uveitis. So the acute phase in this patient was managed with IV methylpred followed by oral steroids, and she was counseled for biologic therapy. However, she refused initially due to financial concerns. She was subsequently started on oral azathioprine and cyclosporine in conjecture with the rheumatologist. So, and she had a relatively uneventful course over the next 5 months. Subsequent to that, in Feb 2020, which was 5 months later, she was maintained on 10 milligrams steroids, azathioprine, and cyclosporine. Her visual acuity was still counting fingers due to a pale disc, but the retinal infiltrates had reduced significantly. However, in the left eye, she had a drop in vision in 2 days. She now had a visual acuity drop from 618 to counting figure at 3 meter. While the anterior chamber was quiet, the posterior pole examination showed presence of multiple areas of retinal infiltrates. So this is the angiogram done in Feb 22, where we can see that in the early phase, there's presence of multiple capillary non-perfusion areas. And in the late phase, there is some amount of leakage, which was a lot less as compared to what she was 5 months back. So clinically, she was pretty much quiet to us. Whereas in the left eye, there was still presence of diffuse areas of small vessel vasculitis as well as periphlebitis, which increased in the late phase as well, along with these capillary non-perfusion areas. So this is the OCT in the right eye, which show presence of these few microcystoid spaces in the posterior pole. Whereas in the left eye, while the foveal contour was normal, there was presence of significant vitreous cells and posterior hyaloid thickening. And this is an OCT passing through this retinal infiltrate region, showing the presence of almost full thickness retinitis. So since she had a lot of complications due to long-term steroids, and she was very unhappy with that, her plan was to give a left eye Ozurdex to take care of the acute phase, and she was walked up for systemic adalimumab. For the right eye, we planned a scatter laser of the capillary non-perfusion areas to prevent neovascularization and its complications. However, 1 day after laser, while the blue arrow shows presence of these laser marks 360 degrees, now she had a drop in vision from counting fingers to hand motion, and there was presence of retinal infiltrates in this eye as well, 360 degrees. So this is a comparison photo taken just 1 day prior, before and 1 day after laser, which actually shows now subsequent to laser, this patient developed 360 degrees presence of retinal infiltrates. So now even in the right eye, she was given Ozurdex and started on adalimumab. On her final follow-up, 2 months after Ozurdex, and she had received 3 adalimumab by this time. In the right eye, she had improved to counting figures at 1 meter. The retinal infiltrates had now resolved, and she was maintained on azathioprine and adalimumab. So we'll be discussing pictures of 3 patients. This is the first patient which I've just shown, which showed presence of retinal infiltrates, which developed 1 day after laser. This is another patient of clinically inactive Behçet's uveitis, where the fluorescent angiogram showed presence of significant capillary non-perfusion area. Again, planned with a scatter laser, and 2 days after scatter laser, this patient developed hypopia on uveitis and vitritis as well. This is the third patient of non-HIV CMV who was managed with oral Valgan cyclovir. And on angiogram, we saw significant capillary non-perfusion areas, again planned for a scatter laser, subsequent to which this patient developed a recurrence of the granular variety of CNV. So what does literature have to show in laser photocoagulation in Behçet's disease? So this is an initial paper back in '96, which showed that later photocoagulation is successful in preventing complications of retinal and disc neovascularization once it occurs in these patients. However, recent literature in 2006 actually shows that in certain patients, retinal laser photocoagulation may actually be ineffective, even in eyes with retinal ischemia, where the neovascularization is secondary to inflammatory pathologies. So our learning points from this case were actually the presence of even subclinical inflammation in either eye. Laser photocoagulation should be avoided. And it's important to increase immunosuppression prior to laser photocoagulation, even if the inflammation is only subclinical. And in the absence of neovascularization in patients of Behçet's disease, laser photocoagulation may be withheld. Thank you for the attention.
Thank you, Uday, for the nice presentation. I would like to move to Dr. Mark Desmet firstly in this case. Sir, what is your opinion? Was it laser photocoagulation that led to worsening of the inflammation and appearance of retinitis lesions? Or was it natural progression, as one eye was already involved and it was sequential involvement in the other eye? Yes.
Well, I think it's a bit difficult to know exactly whether it was the laser that caused it. I've never had a case where doing laser led to a worsening of a retinal of the inflammation. I've certainly seen cases where you do extensive laser, you get traction on the vitreous, and it ends up making the edema worse. So, you can see that with patients that have ischemia and other conditions. What I found a bit surprising for diagnosis of Behçet's disease is the type of lesions that you're seeing in the fundus here, because, my experience with Behçet's, but maybe it's different in India, is we do see these occlusive vasculitis, mainly at the level of the retina. They tend to be transient and disappear. The choroid usually is relatively spared, and it's usually segmental in one area. So if it was due to the laser, this is very severe disease that has occurred very quickly. And yes, inciting events in Behçet's disease can occur with trauma. And if we want to consider the uveitis as a course of trauma, then maybe that might be the case. But I've never seen a case like that, and I've never seen a case reported that presented in this way. I don't think that on the basis of this, I would necessarily change my approach. I usually do laser if there is significant ischemia and the presence of neovascularization, or if because of the amount of ischemia that is present, we see that there's vascular leakage and macular edema. Those are the conditions under which I would do the laser. Otherwise, I would just follow. And in the right eye, the eye was quiet. There was no evidence of any progression. I probably would have waited a bit. But I can't give you a clear answer to your question.
Thank you, sir. Moving to Dr. Monsef. Sir, we did have some evidence of subclinical inflammation in right eye. There were some few microcystic spaces on OCT. If you specifically go in.
Atul, if I might interrupt, I think when I asked for laser, I was just looking at the angiogram. And when I went back, I did realize that even the right eye showed those 2-3 tiny lesions of retinal infiltrates, which probably, I did not look at when I was looking at the angiogram. And the capillary ischemia was so overwhelming that I said we should laser this eye. But in retrospect, I think there was something going on in the right eye as well. And probably we should have given a better systemic cover. Sorry to interrupt, Atul, continue.
Yeah, but the retrospect is always easy, Vishali. I think you did the right thing under the circumstance.
Yes. I would like to congratulate Uday for this very interesting case presentation. I think there are some important issues to be discussed. The first one is that laser photocoagulation, scatter laser photocoagulation, is known to potentially cause or exacerbate inflammation, and we may have inflammation caused by laser photocoagulation, and the risk of post-laser inflammation is probably higher in patients with pre-existing uveitis. Regarding patient uveitis, I agree that any occlusive vasculitis with extensive capillary non-perfusion may benefit from scattered laser photocoagulation. However, new vessels in patient uveitis are less aggressive than new vessels seen in TB and in Irvan syndrome. I think that in patients with TB occlusive vasculitis and in patients with ischemia due to Irvan syndrome, we have to do laser photocoagulation without a delay. In patient uveitis, it is important to differentiate between what we call inflammatory new vessels and ischemic new vessels. In the presence of new vessels associated with ischemia, laser photocoagulation may be indicated. In patients with new vessels, optic disc new vessels, without ischemia on FA, laser is not indicated at all. And even in patients with ischemia and new vessels, we may have some response following medical treatment. So in summary, I think that in patient vasculitis, we can defer the laser photocoagulation, and laser photocoagulation is not indicated, is not an absolute indication in the absence of new vessels. And in the presence of new vessels, we should try to see if medical treatment can have some beneficial effect before considering laser photocoagulation. And when we do laser, we have to have a quiet eye, as quiet as possible eye before. So the laser treatment should be performed under aggressive and effective anti-corticosteroid and immune suppressive treatment. Thank you.
Thank you, sir. The next question to Professor Amod, sir. Sir, we have seen laser-induced complications like exudative retinal detachments also. What laser does is it results in breach of outer blood retinal barrier. Here, what we have is inner blood retinal barrier is compromised due to inflammation. Sir, do you think the superadded breach in the blood retinal barrier would have potentiated the inflammation? Or yes, sir.
Yes, I think that some studies have shown that laser may increase leukocyte rolling and accumulation. And leukocytes play an important role in patient uveitis and in other uveitis entities. And this accumulation of leukocytes may occur in treated and both in treated and untreated area of the retina. So it is important to be very careful before indicating laser photocoagulation in patients with patient vasculitis. Like cases with TB, vasculitis, or Irvan syndrome. And in Irvan syndrome, we have to treat before the occurrence of new vessels, because the course of new vessels in this entity is very poor, is very aggressive. So, like patient new vessels.
Yes, thank you. Professor Amod, sir, your comments on this aspect?
I think it's a very, very interesting and challenging situation. And I agree with Monsef. Now, what we are seeing, and if I can give a name to this situation, is a pathology-like reaction. And as you know, that patient disease patients, we have always known pathology as a skin reaction, but now we know from the work of, Dr. Tutkun also, that, there is, when she did the pathological studies on the conjunctiva, the first time when they did the biopsy, there was nothing, but a couple of days later, when they repeated the biopsy in the same area, there were very heavy infiltrates of leukocytes, predominantly neutrophils and lymphocytes. And that shows that the trauma can induce pathology-like reaction, even in situation other than skin. Well, subsequently, now we know that even procedures like intraarterial procedures grafting, the angiographies, or passing a wire in the arteries can induce, and this is now known as other organs involved in pathogen-like situation. So we have to be aware that it can happen in multiple organs, and laser photocoagulation, is a trauma, is a aseptic inflammation, it's a trauma. And when you are giving those spots, you are inducing the inflammatory reaction. And I'm sure if you had done cytology of those, you would find heavy infiltrates with neutrophils. We have known this from long time from, clinical studies of these retinal infiltrates. They last for a few days, they resolve spontaneously, and you may like to give corticosteroids like you have done in this particular patient. It would have been interesting in case 2, which you didn't give us the details, to do a AC tap and to look at the constituents of the hypopion that was seen. And I'm sure you would find predominantly neutrophils, because these neutrophils are sitting ready to move out, walk out of the retinal vessels and retinal capillaries here in this place. So the moment you touch that retina with laser, it happened. And I'm sure while doing the laser photocoagulation, probably the dead areas were treated, but some of those spots did go into viable retina, which reacted the way they actually reacted. And I would certainly recommend to Uday to publish this patient, as a lesson to be learned for future, to be careful and not do a laser photocoagulation, even when seemingly the intraocular inflammation and vascular inflammation is under control. So one has to be very, very careful in patients with Behçet's disease. Thank you. Excellent case.
Thank you, sir. Thank you, sir. Lastly, I would like to move to Dr. Pulido for the comments. Yes, sir.
I have no comment to add, except that I've learned a lot from these, just like I did with the other 3 cases from this one. And you should not just do this one, but put this one with the other 2 cases of laser-induced inflammation. Because if you just do one, people are just going to say, well, it could be the natural course. But with those 3, it's hard to say it's coincidental, and fantastic cases. Thank you.
Thank you, sir. So interesting cases with we learned a lot. Now I would like to invite Professor Vishali ma'am for concluding remarks.
Thank you very much. Truly an honor for Team PGI to have such wonderful panelists. And of course, we are very thankful to Mohit and Atul for moderating the session so well. Now, since ours is a department full of young people and we have like the best of the best here as our panelists, as a last shot, I would like you to just give a brief statement, all 4 of you, for our fellows and this, like how can we improve further? Just your advice, all 4 of you. We can start with Monse.
Thank you very much. It was very interesting, and thanks a lot for inviting me to contribute to this very exciting and nice panel discussion, and very outstanding and interesting cases. Thank you. Thank you, Vishal. Thank you.
Mark.
You're putting me on the spot, Vishali. I think, the cases were well written up. You did a good literature research as you were preparing these cases. And I think that's probably the most important thing, is that if you see odd new cases like this, you have to sort of go through the literature and ask yourself, has this been described before? What is unusual about what I have? And try to identify these gaps in our knowledge, and then reach out to people. You have very good mentors in India, and I would be more than happy to help anybody that has questions that I would be able to help with. This was a fantastic 4 cases and a great lecture, Vishali. And if ever you invite me again, I'll say yes right away.
Thank you. Thank you, Mark. Jose?
Yes, I'd like to echo Mark's thoughts. And I think with the one good part of COVID is that it has allowed these virtual conferences to occur. And I think we should use this ability to reach out across half the world and learn from each other. And it's a shame that I can't participate with you guys more frequently, because you see cases that I don't see, and probably vice versa. So we can learn from each other, and we should continue trying to do these conferences throughout the world. Thank you.
Thank you, Jose. We are what we are as a department because of the very strong legacy left behind by Professor Amod Gupta. So concluding remarks from Sir.
I think I agree with all, specifically Dr. Pulido, that virtual meetings have made it possible for us to interact more frequently and without much resources, except the time, of course. Apart from that, I think my basic, the way I learned, I think you guys are doing much better now, and which perhaps lacks in parts of the country, is recognizing each individual patient as it comes, documenting each and every which way. And now, fortunately, we have facilities to document each and every case. And uveitis and retina and ophthalmology in general being a visual science, I think exhaustive documentation and presentation at each individual follow-up, asking questions, maintaining that spirit of inquiry which Mark touched, all the time asking questions, what I'm seeing, what I'm doing, is the patient responding, not responding, is my patient come back, writing to call them back. That has been my mantra all my life. To get back patient, unless you know what happened to your patient, you can't rest on your laurels, you know, that you treated the patient. Writing a prescription is not the aim of, you know, a good practice. You know, it should be how well my patient is performing on the kind of diagnosis I made, or the labs that I did, how much they helped, not helped, you know, which way to go. And so you need to look at the patient a year from now, 2 years, 5 years, 10 years, 20 years. And I'm sure Vishali knows we have had patients coming even at 40 years after we saw them. And I'm not sure if the time permits, I'd like to share a small little anecdote of a patient whom I started seeing at the age of when he was just about 22 with ankylosing spondylitis and acute anterior uveitis. I saw him for nearly 35 years. He made about 150 plus visits to the hospital during follow-up. And subsequently, you know, when he started developing progressive loss of vision in one eye, it was ascribed to corticosteroids, sometimes to cataract, sometimes to diabetes, without realizing that the fellow might have something else as well. And when visual fields were done, you know, they were not interpreted. They were just ordered and not looked at. In a year and a half, the patient had gone blind and the other eye was getting affected and was still prescribed to an ischemic optic neuropathy when I think he got to see a neurologist. And, you know, it turned out that he was having a large suprasellar meningioma sitting right there, making him blind. And you know, and he was not too happy about all that. So I think we need to be looking at fresh at every time the patient comes. Are there any new complaints? Is the patient have any features which you might have missed earlier? Have you looked at the labs that you ordered, or you've overlooked those labs? So what I would like to say, be mindful in the clinic, focus all your energies. I know your clinic is overwhelming with the number of patients. That's how you get to see so much pathology, and that becomes your learning ground. But each patient, when it comes, I think all your focus and your energies should be focused only on that patient, only on that eye. Only then we'll be making and having, major breaks in the patient care. But it's an outstanding learning ground. Your institute, I think, I would say that one of the finest anywhere in the world, if I dare say that, and the kind of care you are providing. So kudos to you again, Vishali, and your team. Very, very committed people. You need to solve these issues. Yeah. Thank you. Thank you for the opportunity.
Time to wind up, 7 p.m. And we see all of you next time, which is on 26th of June. And the presentation will be by RP Center, All India Institute of Medical Sciences. Thank you, everyone, once again. And Manisha, any last words?
No, thank you. I think we've had an excellent session and we are bang on time. So thank you so much and for sparing all your time and expert comments.
Thank you.
Thank you, everyone.
Bye.
Thank you.
Thank you.
Thanks, everyone.